Hello physio friends, I am Sudarshan Joshi, instructor from BRAWN Institute, and you all are welcome on our YouTube channel BRAWN for Physio Community. From today's video we are going to start treatment part of forward head series. So let's start. So friends, as we discussed in our earlier videos that forward head posture is consist of three parts. That is head orientation, rounded shoulder and upper thoracic kyphosis. And we already discussed in case study part that forward head or placing the head forward is an attempt of motor control cortex to place the COG within your base of support. And as this reaction sustains for a long time, now there will be facial adaptation in your head, shoulder and thoracic spine, and thus finally forward head presentation appears. For sake of understanding, we divide treatment part into two sections. First, treatment for the cause that creates shift in COG, and second, releasing the adaptively shortened musculature or tight musculature. So start with first part, that is treatment for the cause that creates shift in COG. As we assess posture in sagittal plane, we see alteration in pelvic in terms of either tilt or shift, that is anterior posterior tilt or anterior posterior shift, along with altered foot and spinal alignment. So to cover this all, we categorize it into four sections. First is alignment for ankle, second one is alignment for pelvis and thoracolumbar junction, third one is thoracic mobility, and finally craniovertebral CV junction alignment. So in today's video we are going to discuss with ankle alignment. So alignment of ankle. For assessing alignment of ankle, we take an angle, that is angle between foot and tibia, and it should be 90 degree for a good posture. If it is less than 90 degree, that is, you can say in other words, dorsiflexed ankle, or it is more than 90 degree, you can say a plantar flexed ankle. A displacement of this angle, either less than 90 degree, that is dorsiflexed ankle, or more than 90 degree, that is plantar flexed ankle, will lead to malalignment upward towards the head. And malalignment is very evident in terms of pelvic tilt, anterior or posterior pelvic tilt, or a pelvic shift, anterior or posterior pelvic shift, as we see in sway back posture or kypholordotic postures. So to achieve this 90 degree alignment or good alignment, we will deal with two structures. First one is ankle retinaculum, and second one is balance between ankle dorsiflexor versus plantar flexion. So let's start with ankle retinacula. Ankle retinacula, it's not a static structure for the joint stabilization like ligament, or else as from its other work, that is anchoring point of the tendon. Instead of this, it is a specialization of fascia for local spatial proprioception for the movement of ankle and foot. As we all know that a structured sensory input can modulate a motor output, as proprioceptive input from ankle retinacula provide a precise position sense of ankle, and thus it has a potential to modulate our motor response. So before going to treatment, we understand which to look for. First, on observation, The skin will look shiny and taut like without wrinkles. It may feel dry. The tone or quality of each person's connective tissue is unique. Restricted tissue feels sluggish on palpation. So we are going to use dorsum of our hand. Pressure should be gentle. Our focus should be on traction rather than pressure, because lengthening of elastic component is achieved with it better. The intention is to allow the body's inherent ability for self-correction, return and eliminating pain. Ask the patient to move toes gently as the tissue begins to soften and toes move more freely. Understand lengthening has initiated. This hands-on approach of myobalance offers a front stimulation through mechanoceptors in retinaculum, which requires central processing at spinal cord and cortical level for response. A front stimulation frequently results in efferent inhibitions, so that relaxations result in tight tissue. And there are few reactions after this release. Your patient while walking may feel imbalance for few steps. Don't worry, it's a result of increased proprioceptive response. Now a proprioceptive map in your cortex get altered and your brain is adjusting, or your brain is creating new motor program according to a altered proprioceptive input. Now move to the second part, that is balancing between ankle plantar flexor and dorsiflexors. As usual, as name suggests, we are trained to think like that they are meant for moving our ankle either in plantar flexion or in dorsiflexion. But they have more important work to do, and it is to align the tibia vertically over the foot. When foot is stabilized through your whole body weight. So they are acting invertly, that is from insertion to origin, and thus maintaining a vertical alignment of tibia. And this vertical alignment actually depends on dorsiflexors and plantar flexors, but few other groups are also still there that can have potential to affect this. That is, one is tibialis posterior as well as your toes flexors and extensors. Though in this particular section we are going to discuss over dorsiflexor group as tibialis anterior and peroneal, and a plantar flexor group as a gastrocsoleus complex. So if angle is less than 90 degree, we need to interfere with our ankle dorsiflexors, and if angle is more than 90 degree, we need to interfere with our plantar flexors. But work is not completed here. The next important thing is, once you frame a range or once you gain a new range, always train your muscles for that particularly newly gained range. If not, it will again create a recurrence. So let's take one example of gastrocsoleus complex. If our angle is more than 90 degree, we need to release a tight and short gastrocsoleus complex. And definitely after this release, your alignment of tibia will become neutral. But it's not enough, because from a long time my plantar flexors, that is gastrocsoleus complex, is trained to work efficiently in slightly plantar flexed foot. So it is exact range where it gets trained to work efficiently. But as now our tibial alignment is normal, that is a neutral ankle, in this particular range, there are high chances that this might be felt weak or inefficient to control the ankle. And if this is the case, our cortex will sense that in this neutral range we have less stability, and a less stability always perceived as a threat for our sensory cortex, and again this sensory modulation will alter our motor program, and cortex will try to assume the position which is more stable. So again there are high chances that the tibial alignment will alter into slightly plantar flex position as your gastrosoleus complex is more trained in that particular range. So never forget, once you release a muscle, a tight or short muscle, always train it for newly gained range. If you will not do this, there are high chances of recurrence. And as you will align the ankle, you will see a drastic change in pelvic alignment also. A exaggerated tilt, that is anterior posterior tilt, or a shift, example for square leg posture, it will get diminished as ankle alignment will restore. So friends, for sake of understanding, we divide treatment part of forward head posture into two sections, and in this particular video we discussed over the ankle alignment via treating ankle retinacula and balancing between plantar flexor versus dorsiflexor. This was the first video of treatment part of forward head series. In next one we will discuss over the pelvic and thoracolumbar junction alignment as well as over thoracic mobility. So friends, see you soon, and don't forget to like and subscribe our channel, and please spread the knowledge by sharing this video in our physio community. Thank you very much.